My name is Naveen Kapur. I'm an interventional cardiologist and advanced heart failure specialist at Tufts Medical Center. The title of my case presentation today is When in Doubt, Create a New Way In and Out. This is describing a novel approach to single-stick PCI with VA-ECMO and cardiogenic shock. The case is a 70-year-old gentleman without any known past medical history who presented to an outside hospital with dyspnea and weakness after 2 weeks of chest pain. On arrival, the patient was hypotensive and urgently brought to the catheterization laboratory. The admission electrocardiogram is shown here with anterior Q waves, suggesting a late presentation anterior STEMI. The patient had a coronary angiogram performed at an outside hospital, which was reported to show a 50% terminal left main stenosis, thrombotic occlusion of the proximal LAD, 80% ostial circumflex, and 70% mid-RCA lesions. During wiring of the LAD, the patient developed PEA arrest with return of a spontaneous circulation in 10 minutes with CPR. An Impella CP was inserted and started at 3.1 liters per minute. The patient had persistent hypotension requiring 4 vasoactive agents, and VA-ECMO was then initiated. VA-ECMO was initiated using a right femoral 25 French multistage venous cannula, a 19 French arterial cannula in the left femoral artery with a 7 French antegrade perfusion sheath, and in the right femoral artery was the 14 French sheath from the Impella CP device. This totals to 65 French total in terms of vascular access. The patient developed left femoral artery bleeding, which required transfusion of 8 units of packed RBCs. Hemoglobin was 6.1 with a lactate of 3 and AST in the 4,000 range, with associated creatinine of 2.3 and an INR of 6.3. On the Impella configuration, the patient's hemodynamics are shown here. The patient was then transferred for further management, and on arrival, the patient was evaluated for emergent coronary bypass surgery. However, due to hemodynamic instability, the patient was declined for surgery at that time. Pressors were weaned off while on VA-ECMO. Dobutamine 5.0 was initiated. An echocardiogram was performed and showed an ejection fraction of 15% with anterapical thinning. The patient was opening his eyes but had no purposeful movements on exam. PCI of the RCA failed to improve myocardial infarct myocardial function. On ICU day number 5, the patient was unable to wean off of VA-ECMO or Impella due to hypotension. These images illustrate the relatively straightforward PCI that was performed using a radial approach for the RCA. And as you can see, there are 2 drug-eluting stents placed to the mid-RCA and proximal RCA. On ICU day 8, the patient remained unable to wean off of VA-ECMO or Impella and was referred for high-risk PCI of the left main and left circumflex. The right radial artery was thrombosed due to prior PCI access times 2. Left radial artery was thrombosed due to prior arterial line for monitoring. The right femoral artery had the Impella in place. The left femoral artery had the ECMO cannula and antegrade sheath in place. The patient was also fully anticoagulated on VA-ECMO. So at this point, we asked ourselves, what are our access site options? We could go through the brachial or axillary approach. We could try an ulnar approach. Or could we avoid another arteriotomy, perhaps exchanging the Impella CP for a new CP device or CP approach for PCI, or single access PCI, or perhaps other innovative approaches. At this point, we decided to go ahead and develop a single stick access approach using the VA-ECMO arterial return cannula. We first confirmed that the patient tolerated low flow on ECMO and increased the Impella CP flow at the same time. We then used a combination of a large bore sheath with ECMO tubing and a Y connector, attached this to the arteriofemoral cannula, reconnected the ECMO circuit, and de-aired the sidearm of the connecting unit. Through this connecting unit, a 7 French Q4 guide was delivered and engaged the left main for PCI while on full Impella support. You can see here that this is the final configuration prior to initiation of PCI. ECMO flows were 4.2 liters per minute at 4,000 RPMs. With the 7 French guide through the ECMO arterial cannula, we did see a slight decrement in the flows from about 3.8 to 3.4 liters per minute. However, this provided adequate support with the Impella device in as well to perform uncomplicated left main to ramus intermedius branch PCI. This was accomplished using 2 run-through wires, kissing predilation, and delivery of a 3.0 by 32 millimeter drug-eluting stent, which was then post-dilated and interrogated with intravascular ultrasound for optimization. These are the pre-PCI images on the left, and the post-PCI images are shown on the right. Now, it's important to note that when we completed the PCI, the guide and the sheath were removed through the connecting unit. ECMO was clamped, and Amplatz wire was then inserted through the connecting unit into the aorta via the side arm. This was then exchanged for a new 19 French arterial cannula. This was then reconnected to the antegrade perfusion sheath, and ECMO was reactivated. This allowed for us to insert ourselves into the ECMO circuit, perform our complex PCI, and remove ourselves from the ECMO circuit, all with minimal interruption to ECMO flow. During the same procedure, we then also weaned and removed the Impella CP with a post-closure technique and had good hemostasis in the right femoral artery within about 10 minutes. On ICU day 11, the patient tolerated the VA-ECMO wean and was decannulated on ICU day 12. The patient's cardiac status was stable, but the patient was unable to extubate due to poor neurologic status and subsequently developed pneumonia. The patient was made comfort measures only on ICU day 28 and expired. We've illustrated a new era for single-stick PCI using VA-ECMO to limit vascular complications and improve outcomes. This is a recent report that was published in CCI showing the untreated acute limb ischemia associated with ECMO is also associated with 100% in-hospital mortality. And as we engage further with mechanical support, vascular protection strategies are going to become a primary focus, especially for patients with cardiogenic shock requiring full hemodynamic support and complex PCI. Thanks very much for your attention.